Hello friends, I am Professor Dr. H.M.P. Singh. Again, we are going to discuss the part 2 of the acute coronary syndrome, which is the pathophysiology of acute coronary syndrome. I am sure you must have seen by now my first video, which is the introduction to acute coronary syndrome and the global statistics regarding the prevalence of this disease. In this part, we are going to look into the pathophysiology of the disease, and I'm going to talk a little bit on how this disease happens. I'm sure you know this, that there are two pathologies involved here. One is the atherosclerosis, which is the basic theme of the coronary artery disease, and on top of it there are platelet aggregations or the thrombus formation. The disruption of the coronary artery actually starts this atherosclerotic process at a very younger age, around the age of 15 years. So if you look at the lumen, this is small plaque in the subendothelial tissues, and this plaque gradually grows in size and occupies the 40% of the lumen. Till that time, surprisingly, there is no symptoms and the patient do not feel anything. This is 15 years of the silent period when this pathogenesis keep going and the patient is unaware. The first symptoms starts at the age of 35, nearly 35. And then there is a cascade of things which are happening, which lead to disruption of this coronary artery. And on the top of it, platelet aggregation and activation of the coagulation cascade. And there is also on top of it, there are neurohumoral mechanisms, and there is a vasoconstriction, and this intraluminal thrombus ultimately obstructs the whole of the coronary arteries and produces an acute MI. Severity of the coronary vessels, obstruction, extent of the myocardial involved, this determines the clinical presentation. The acute MI may be as small as 10 to 12 square millimeter, or it may be a large MI. So it depends on the person to person and also the underlying comorbidities. Most common factor which occurs and lead to this myocardial ischemia is the result of an obstruction to the coronary arteries in the form of atherosclerosis, which I already told you. In addition to this fixed obstruction, there is some variables which determines the tone of the smooth muscles. There are some hematological factors also has been postulated. Even they have now said that the viscosity of the blood increases, the flow of the blood decreases, and there are some other dynamic and variable things which are occurring in the formation of this acute coronary syndrome. Looking to the atherosclerotic process, as I said, this is an inflammatory process, starts very early. There is a accumulation of lipid, macrophage, and there is a smooth muscle cells. In the smooth muscle cells, in the intima, the vascular endothelium plays a critical role in maintaining this vascular integrity. The mechanical shear, there are certain stresses by the essential hypertension or the modified low density lipoproteins, associated diabetes, elevated levels of homocysteine. There are some immunological factors, free radicals from the smoking, certain infections like chlamydia infections or H. pylori infections. All these lead to alteration in the endothelial injury and thus producing this particular pathogenesis of coronary atherosclerosis. If you look at this picture, you can see that the lumen, which was early part, which is 100% clear, and in the later part, you find that this is a atherosclerotic plaque. This picture I have taken from our textbook of Kumar and Clark, and this is not producing any symptom at this stage till the 40% occlusion is already taken place. We are trying to make a diagnosis at an early stage, earlier than the changes which are seen in ECG, so that one can do some preventive cardiology and prevent this particular disease of coronary arteries. But still we are at a very early stage to diagnose this particular occlusion of the coronary arteries by something like near infrared rays and other possibilities. People are working on these areas. If you look at the plaques, this is again a vertical diagram, and it shows that the whole of the section, you can see that intimal occlusion at the subintimal level. On the top of these atherosclerosis, there is another mechanism which is playing part into the formation of atherosclerosis, coronary artery disease, and that is the thrombosis. Two mechanisms are responsible again here. The first process is superficial endothelial injury, which involves denudation of the endothelial covering over the plaque. And then this particular thing exposes the lumen to the platelets, and this is highly thrombogenic. And then on the top of this collagen and the reaction to the platelets, the thrombus is formed. There is a second process which is more severe, which lead to deep endothelial fissuring and then advanced plaque with a lipid core. This all lead to that the blood invades into the lumen, the walls of the coronary arteries, and triggers the formation of the thrombus in a short time. This is again produced by macrophage and exposed to collagen, and therefore the thrombosis in this process will lead to 100% occlusion. We look at this picture, which is showing a plaque, which is the silent killer, that is a atherosclerotic plaque. On top of it, there is a deep endothelial injury leading to a occlusion. And this process of evolution of myocardial infarction may vary from person to person, starting from anything like a few minutes to as long as a few hours. If you talk at the approach of acute coronary syndrome, there are certain things which we have to keep in mind when we are looking at the different areas. One of the important thing is all patients coming to you with a chest pain. We have to keep this possibility of a coronary artery disease. A thorough history is required about the character of the pain, the chest pain, the onset, the duration, the location and the radiation, aggravating and relieving factors. All these are an important components of when we take the history of chest pain. If somebody comes and tells me that there is a pain on the whole of the chest, then I am more worried, rather than if somebody tells me with a pinpoint that this pain is secondary to a coronary artery disease. There are certain typical presentations, but there are certain atypical presentations. I remember in one patient, he come to me that there is a pain in the jaw, and this patient was diagnosed by a dental surgeon as a toothache, and the smart dental surgeon took off his molar tooth. But the pain did not relieved. So many times the patient will come to you with a pain in epigastrium, more gastric symptoms, pain radiating to the back, sometimes to the tip of the finger. All these need to be taken into account when you are approaching to these patients who come to you with a chest pain or something similar to the coronary artery disease. There are some characteristics which we have to keep in mind during the anginal chest pain. Dull crushing pain, which is typical of angina. Less suggestive angina is sharp shooting pains. Duration around less than 20 minutes. In less suggestion of angina, it is more continuous pain. Sometimes in anxiety neurosis, you get the patients coming to you with a pain lasting for longer duration. The onset is gradual, whereas in non-anginal pains, it is a rapid onset. Substernal is the usual in the anginal pains, whereas it goes to the lateral chest wall or tender to pulpit like costochondritis or muscular pains. It is reproducible with exertion in case of angina, and it may not be reproducible, or it may be with breathing or Autonomic symptoms may be present with angina, or it may be absent with less suggestive of angina. So when we go into the history of these patients, there are certain characteristics which we point out towards the coronary artery disease. There are certain causes which we have to keep in mind while going approach to the ACS, atheroma, thrombosis, coronary spasm, embolus, corneal ostial stenosis, which could be due to a congenital defect, or coronary arthritis, as in systemic lupus. There are some other causes which may be contributing to the flow of the oxygenated blood to the myocardium and decrease in the oxygenation, which is anemia, which is again a contributing factor, or carboxyhemoglobinuria. Hypotension, which may be again decreasing the coronary perfusion pressure. There are certain risk factors which we usually emphasize, and there are some changeable risk factors, which we call it as a modifiable risk factors. And there are certain risk factors which are there, cannot be changed, like age or male sex or premenopausal women, which are safe, then positive family history. Whereas the changeable risk factors may be hyperlipidemia, cigarette smoking, hypertension, diabetes, lack of exercise, blood coagulation factors, C-reactive proteins. These are some of the things which we have to keep in mind. And then there are some factors like homocysteinemias, personality disorders, obesity, gout, soft water, contraceptive pills, heavy alcohol consumption. So you can see that many of these things can be prevented. Therefore, a lot of things are there by which the coronary artery disease can be prevented. Look at the total cardiac symptoms, maybe chest pain, there may be fatigability, sometimes they only come with fatigability. There may be dyspnea or palpitation, pre-syncope, or sometimes patient may come to you with attacks of syncope. So all these factors you have to keep in mind when we are talking of a diagnosis in the coronary artery disease. For this particular part, I think this is enough. I will see you again in the part 3. Thank you so much.